So as Anna said, I'll be talking about both harm reduction and abstinence housing all under one roof. So Project Renewal started its harm reduction program back in 2003 with 40 units. They operated it under a scattered site model. The idea was that we would place clients in communities in the Bronx, Brooklyn, and Manhattan. And now today we have 108 harm reduction apartments. Although this was Project Renewal's first attempt at harm reduction housing in 2003, Project Renewal has operated scattered site housing since 1993 with shelter plus care contracts. The abstinence-based housing started back in 1993, and now we have 130 abstinence-based apartments. So in 2009, as our abstinence-based programs started expanding, we decided to put all of the programs under one roof. So now we have harm reduction and abstinence-based staff all in one office. The office space is very unique. As she said earlier, it's in Upper Manhattan, and we have 3 apartments that we've rented, and we've turned them into office space. It operates under a drop-in model. The clients are allowed to come and go as they please during office hours. There's computers for them to use. There's telephones. The staff is there. At least one staff member is there in the office to take care of any clients that have drop-in concerns. It's absolutely no need to have an appointment. They're just free to come in and go as they please. In this office now, we have our entire clinical team. Our team consists of 11 case managers, 2 peer counselors, psychiatric professionals. We also have a clinical coordinator, a benefits advocate, and we also have occupational therapy students from Columbia. In this office space, we run various groups, both clinical and recreational groups. Our clinical groups include seeking safety, smoking cessation, and health and wellness. Our recreation groups include movie trips, bingo nights, and trips to the park. So when Project Renewal decided to combine the programs under one roof, we had 2 major questions. Would the mixing of the populations in groups and social activities be a problem? And in the long run, which programs would do the best? There were also some concerns. Would the abstinence clients relapse because they were around active users? Would mixing the populations create a 2-tier model? The idea that staff favored the abstinence clients over the harm reduction clients. And would the office drop-in center lose its home-like feel? As I said earlier, when it started in 2003, there were 40 clients in this office. Now there are 240. So again, just to review, the populations, we have 108 harm reduction and 130 abstinence. Most of our clients were referred to us by the shelter system, long-term treatment programs, and the original 40 often came from outreach teams. Most were chronically homeless. About 30% are dually diagnosed and considered SPIMI, but another 40 to 50% have suffered from some mental illness. And we see a lot of Axis 3 with physical diagnoses. So the proof was really in the numbers. So in 2011, we created our logic models for the programs. Our thought was that the abstinence programs would be much more stable clients and our harm reduction clients would lag behind. We decided to look at 4 major factors: rent collection, group attendance, doctor and ER visits, and our retention rate. The only area where we thought the harm reduction clients would do better than the abstinence was with group attendance. Since the harm reduction office was already there and the harm reduction clients were used to coming to that program, we thought, well, they're going to come to more of our activities. What we found, though, is that the populations are remarkably similar. Our goal for abstinence rent collection was 85%, and we set the bar very low for harm reduction at 70%. As you can see from this graph, the abstinence clients do collect rent at a higher rate, but not a significantly higher rate, including in January and February, where the harm reduction clients actually exceeded the abstinence-based client. And this May, which is not on the slide, the May collection rate, the abstinence collected 79%, and the harm reduction collected 85%. I think these numbers surprised a lot of people because the idea is if you're actively using, you're chaotic, you're not paying your bills, you're not doing what you're supposed to do. But what we found is that the clients, regardless of their program, value being in housing and value taking responsibility for what they're supposed to be doing. The next is quarterly group attendance. Again, the abstinence clients do attend groups a little more frequently than the harm reduction, which surprised us just based on the office setup. But the abstinence clients are encouraged to attend a group where the harm reduction have no group requirement. Primary care and ER visits. The primary care is measured through 6-month studies, so we ask the clients to self-report if they've seen their primary care doctor in the last year. Of our abstinence clients, 87% of the clients said that they had, and of our harm reduction, 80%. Again, not a large difference. The ER visits, though, there is a difference. With our harm reduction clients, we saw 33 clients go to the ER in the last 6 months and 3 go to the psychiatric ER. Whereas with the abstinence, we only saw 16 in the medical ER and 0 in the psychiatric. And the housing retention rate. So what we do to calculate this number is we look at clients that were in housing in May of 2010. And we see which of those clients are either still in our program or have been successfully placed out. So for abstinence-based housing, we have a 92% retention rate, and for harm reduction housing, we have a 90% retention rate. Again, a very similar retention rate between the two populations. So I can talk a lot about numbers and say this and that and the third, but I want to talk about 2 clients. So we have, and with their permission, I'm going to talk with them using their first names. We have Kendrick and Ronald. Kendrick is in his 70s and is in our abstinence-based program. He's been there since 2009. He's a fixture in the office. He always has a story. He loves the Yankees. Ronald is in our harm reduction program. He's been in the program since 2011. And as I was preparing my speech for this, I realized I didn't realize how Kendrick and Ronald met. They were in the same shelter, but several years apart. But a lot of our clients have crossed paths in various ways. So I pulled them into my office as they're signing their consents for me to present about them. And I said, so how did you 2 meet? Kendrick goes, Ronald came to my store. If you know Kendrick, Kendrick works part-time at a little store on his street. And Ronald, went in there and they met each other. And then Kendrick goes, Ronald also moved into my building. And I said, oh, okay. And Ronald quickly replies, yeah, I moved into your building, but I got the penthouse. Ronald lives on the 8th floor and Kendrick lives on the 7th floor. The 2 of these travel to and from the office together. They're instant friends. If you ask them which program they belong to, neither of them would be able to tell you. When you hear Ronald out in the living room bragging about his basketball skills, Kendrick is quickly to correct that he's the one that taught Ronald how to play basketball. Basically, the point of this little vignette about the clients is that they don't know which program they're in anymore. They don't know if they're in the abstinence-based program or the harm reduction program. And the great thing about the staff is they sort of lost track too. We've used a lot of motivational interviewing training, including an ongoing workshop for the last year, which just reinforces to our staff the idea that you want to meet the client where they're at. It doesn't matter if they're labeled as an active substance abuser or a client that is early in their sobriety or long-term sobriety. We found that the clients really just mesh well together and have created a community of their own. So just to conclude, again, the abstinence clients do slightly better with rent collection, group attendance, and less ER visits. But mixing the 2 populations can be done with great success. Today, like I said, if you ask a client where they belong, they simply say in homes now.